My dear friends, I'm sure that we all experience a little amount of stress when we're operating on a one-eyed patient, and this would be especially more exaggerated if the only seeing eye has got a lot of challenges. Like in this particular case, a small pupil, pretty hard cataract. The other eye was lost after cataract surgery 5 years ago to an infection, and the eye is phthysical. Patient is apprehensive about the surgery, but I assure him that things would go fine when I take up this case. But deep down, there's always a sense of stress that's lurking inside of me. So I start off by first staining the anterior capsule with trypan blue, and then I make a side port incision at 9 o'clock in order to implant the pupil dilating device. So the movements are seeming to be a little jerky because I think a little amount of adrenaline is pumping within my system while I perform the case. I want things to go well for this patient. So taking the due amount of care, I am implanting this pupil dilating device as best as I could. Preoperatively, this patient had a conjunctival swab. He was started on antibiotics 3 days before the start of the surgery, and he was explained the prognosis of the surgery. He was told that he had a small pupil, and finally we took him up with midazolam sedation and a block. Please note, while trying to position the device, do not sweep underneath the scroll because this will cause it to pop out of the pupillary edge. So now we have a square pupil which is 6 millimeters. I'm initiating the capsulorhexis at 1 o'clock position. I'm trying to create a rhexis size that's close to 5.75 millimeters because the cataract is not a soft cataract. It looks like about grade 2 to 3 nuclear sclerotic cataract, and I want to take no chances at all. So I have a nice round central capsulorhexis, quite happy with the way it turned out, and then I perform cautious cortical cleavage hydrodissection. So as I perform the cortical cleavage hydrodissection, I do not see the fluid wave, but I see the central part of the nucleus rise. And then I gently decompress the center of the lens, and I know this lens is going to rotate. The next step is to start with phacoemulsification. My parameters in this case is that I'm using a power of 40%. I'm using a micropulse mode, a vacuum of 350 millimeters of mercury in my Venturi Stellaris machine. And the technique I'm going to use in this patient is a direct chop. After decapping the superficially lying epinucleus, initially with vacuum, I go through the steps of the direct chop by burying the phaco tip into the substance of the nucleus and initiating the crack, and I'm trying to create a through and through separation. Normally I would flex the chopper and go deep into the crack and separate it, but in this case I'm being a little cautious because it's always playing in the back of my mind that no risks have to be taken whatsoever in performing this case. So what really happens is that although I'm able to initiate the crack, I'm not able to make sure that this crack separates right through the center of the nucleus core. And this is, I think, mostly because I'm being a little overcautious. So remember that sometimes being overcautious can prevent the free flow of surgical skills, and you may actually end up underperforming. So the central amorphous core is worked loose and emulsified. And now the fragment removal is taking place very carefully in the micropulse mode itself. Even though the pieces are connected to the center, once I impale and bring it to the safe zone and emulsify, they work themselves loose from the heminuclei and come free. So now I have just one more heminuclei to emulsify. I'm just praying that this goes well. I initiate the crack, I separate the fragments with a kind of a rotation maneuver, and I go ahead and emulsify the nucleus, always remaining, as we all know, within the central safe zone. The phacoenergy is given in short bursts. Adequate time is given for the nucleus to come and impale itself onto the phacotip before activating the phacoenergy. So finally we come to the last piece. In my mind, I'm heaving a sigh of relief. My adrenaline rush is coming down a bit. However, there is a little bit of thick epinucleus that's left behind, and also a small fragment piece that is stuck in the capsular bag. So I go in again in the epinucleus mode, and I aspirate this little fragment, and I put the dialer underneath the epinucleus shell, lift it up, and that's it. The cortex is pretty sticky, and I'm making sure that I don't inadvertently engage the anterior capsule or create a zonular dialysis in this patient. I'm washing off all the cortex. I'm cleaning up the bag as best as I could. So because of the strobal hydration that's occurred around the incision, it's quite difficult for me to see the subincisional cortex, but I'm able to get by with a sense of feel. The implantation of the intraocular lens is now going on under viscoelastic, and this is implanted into the capsular bag. The viscoelastic is then washed out from behind the intraocular lens. I find that the posterior capsule is pretty thin in this patient, and it's tending to trampoline as I go behind the IOL, which is the reason why I immediately come out from behind the IOL and position the lens not by the usual pivot rotation that I do, but from superior to the surface of the lens. I position it and bring it to the 3 and 9 o'clock position, a position which is believed to reduce photic phenomena like negative dysphotopsias to a great extent in the postoperative period. So the final step is the removal of the pupil dilating ring. So each of the scrolls is released and freed from the pupillary margin first. So one way of releasing this pupil dilating device is to engage the scroll, lift it, draw it inwards, and then use the iris repositor to just tap the iris behind. So you engage the scroll and pull it towards the center, and then tap the iris gently, and the scroll gets disengaged. It's quite simple. The final removal of the ring from within the eye is done with the help of intraocular forceps. Make sure that you slightly depress the inner corneal lip so that the scroll doesn't get stuck behind the inner corneal valve. So this is the end of the procedure. The pupil looks acceptably round. The cataract is successfully managed and the wound is nicely secured. So a tough and challenging case, which was made more challenging by the fact that he was a one-eyed patient, was successfully managed.